Good evening, everybody, and welcome to our webinar tonight, Living with COVID, a primary care update on management and treatment. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. I sit on Anawan land in the Northern Tablelands in Armidale. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. We have a great lineup of speakers for you tonight, as you can see, and I'm just going to hand over to Kimberly Booth, who is manager of our COVID response team, and she will do a PHN update and an introduction. Thanks, Kimberly.
Thank you very much, Jen. And I also would like to acknowledge the traditional custodians of the various lands that we're meeting on virtually this evening. I am on Darkinjung land on the beautiful Central Coast. So I would also like to pay my respect to elders past, present and emerging. Now, what I'm going to do is just share my screen and hopefully make sure I do this correctly, because I am going to run through a couple of slides that John Bailey, who normally comes along and joins the doctors on this webinar, regular webinar, he's unavailable this evening. So, okay, did that work? And please, if that did work, let me know. A nod would be wonderful.
Yes, it did, Kim.
And I have the correct screen up at the moment?
Yes, you do. Just before you go any further, I forgot to say to everyone, don't forget to type in any questions that you have, because we're allowing plenty of time tonight for lots of Q&A.
Thanks, Jen. Okay, so a couple of things that we just wanted to give a bit of an update around was, the first thing was that a slight change to the ordering process for pulse oximeters for patients under the Living with COVID package. Up until now, any requests that have come through for the PPE bundles have included a pulse oximeter as an automatic allocation. However, we'd like to streamline that, and in terms of reporting allocations, we have decided to implement the system that you can see on your screen. So from the 4th of February, what will happen is, similar to the form that you've been using or the link that you've followed to order your PPE bundles, there will be a specific dedicated link for pulse oximeter requests. And obviously, in line with Department Commonwealth guidelines, they're intended for general practices, GP respiratory clinics, and art shows that are caring for COVID positive patients in the community. Still, the current maximum 5 pulse oximeter limit is in place. However, if you wanted to order all at once or just one per patient, one for individual patients, that is available as well. So the two ways that we would like to distribute, or the systems that we'd like to implement around the pulse oximeters, is you can request to either have them delivered directly to your patient, or we could deliver them or arrange for delivery to the practice, and then you can send them on to your patients. As you work your way through the online form, basically your response to the first question will then lead you to the area that's appropriate in terms of whether it's practice delivery or patient delivery that you've chosen. Next slide. Okay. I was also asked just to update everybody that these webinars that are so popular and are attended by a lot of you all the time are going to be a regular occurrence. So they're going to commence every Tuesday at 6:30 p.m. starting from 8th of February. So this little slideshow will get sent out with the rest, or be loaded onto our website with the rest of the presentations this evening. And any of the links or information will also be included if you want to access it. I think John's mentioned this before, and it is the great question. So it is a platform that we've set up to capture really good questions that are coming from you that are out there experiencing this on the front line, all around everything that we're dealing with in terms of COVID. So you can visit it via clicking the link when you receive this presentation, or you can just scan the QR code and pop us in a question, or if you'd like a topic covered in one of these regular webinars. Here comes the confusing part, and I've tried to make it as simple as possible, but what was a simple system around PPE requesting has slightly got a little more involved, just in terms of what can be accessed, who it can be accessed by, and what's included in these PPE bundles. So what we've done is actually retire essentially the old surgical mask request form, and we've now made, which you can see on your screen on the right hand side, a general PPE request form. Still got the same requirements, eligibility, the same questions, it's just on a different platform. On the left, you'll see the PPE bundles. Each has its own link and its own form, just because they're very specific about who can access and what's included essentially. So those links are also on our website, but obviously we'll send this out so you can use these links in the presentation. And the last thing I was asked to just touch on was we've been asked to just advise that for anyone in the area of Raymond Terrace, the GP respiratory clinic are currently seeing COVID positive patients face-to-face. All patients are reviewed by GP, they accept all ages, and they've got online appointments available via HotDoc, open Monday to Friday. Now, I think what I'm doing now, that was all for the PHN aspect of this. I'm now going to hand over to Dr. Joanne Wood, who is going to give us a little bit of an update, and then we'll move through to, I believe, Dr. Mark, or it might be Michelle after that. Thank you.
So we're actually going to hand over to Michelle. So I'll just make you the presenter, Michelle, so you can share your slides.
Perfect. Hopefully we're on and you can see my slides. Perfect.
Yes.
Okay,
yes.
so I'm actually going to not show my webcam because I think sometimes it affects the sound. So I'm just going to hide myself and I'll just talk to the slides. Okay, so thank you everybody for being here. Your time is precious. We do very much appreciate you joining us. I'm just going to run through some hot topics. We're just going to be focusing on stuff that's changed recently. I'm not going to pretend to cover everything by any stretch of the imagination, but if you have got questions, please do pop them in the questions box and we'll try to answer them at the end. So let's get this going. So this is just the COVID-19 FAQs, which is now housed on the PHN website. And if you do submit one of those questions through the link that Kimberly was mentioning, then they come through and we try and answer them, and that's where they live. So that's the link. What I'm going to talk about is these few things. It's not necessarily going to be completely definitive, but it's kind of going to reflect the state of play right now. So children's vaccines, these are the current data across the region for how we've done up to the 24th of January. And actually, I think that's pretty impressive, seeing as the rollout only just started and 22.9% of children in the age group have had their first dose. Obviously, there's quite significant geographical variation. Some of that might be because people haven't actually had their doses delivered, I'm not sure. But we've got off to a flying start. I think it's really helpful to look at the side effect profile, and Osvax Safety has come out with a report from the 16th of January, which shows that compared to the teenagers and indeed compared to adults, children aged 5 to 11 have fewer and less severe side effects. So overall, nearly 30% had at least one mild side effect, but as you can see, most of that is a bit of a sore arm, and only about 2% reported missing work, study or school, which compares to around 8% of adults after their first dose of Pfizer. So I think it's a pretty strong message to go out to parents that actually the younger kids tolerate these vaccines really well, especially with just thinking about what's happening next week with everyone going back to school. I think there might be a bit of reluctance to vaccinate, thinking that your child might then be, unwell for a couple of days after vaccination, but that's just not really a very common event. So if you want to find out more about that, Ausvax Safety has got full reports on adults and also teenagers and this age group that we're thinking about at the moment with the 5 to 11s. This is just to sort of reflect the teenagers, and as you can see, the 12 to 15s and 16s to 19s had a lot more missing work, study and routine duties after their first dose, but even more so after their second dose. So it's just to show that at the moment it's looking like it's a bit different in the primary school age children. Just some other bits and pieces, update on the Pfizer for 5 to 11s. So it has come out that severely immunocompromised children need to have a third primary dose after, so 2 to 6 months after their second dose. So that's just in line with the requirements for all immunocompromised people. It's just been added as a thing for the 5 to 11s, and that probably are not very many of those children. They would need to be significantly immunocompromised to be eligible for that. The PHN is looking at ways to support the rollout, as Dr. Marie Puxty was mentioning in the last webinar, and looking for ways to really adapt to the local sets of circumstances. So if you haven't already filled in your form about support for children's vaccinations, please do so. We've noticed in the practice suddenly the appointments seem to have dropped off, and of course next week they're all back to school, so just a bit of a thought about trying to schedule appointments outside of school hours. The other thing that I've noticed with doing these children in clinic is that there is a lot of screaming, and unfortunately, and although it's well tolerated, screaming is an aerosol generating procedure. And these children are not necessarily wearing masks, they're under 12. So we have, and we're doing these in small rooms with the window open, but we've moved to a respirator and eye protection rather than a surgical mask and eye protection for the pediatric clinics. We don't do that necessarily for the adult clinics because we're not having aerosol generating procedures with mask-free people in the adult clinics, but it's just a tip. It's not based on any, I haven't seen it written down anywhere, but it seems to make common sense to me. The other thing that's happened is that the you now can get the coded vaccine, or at least on best practice. If it's not there, you can just record it, as I said last time, as just the adult vaccine, and the AIR will still pick it up. It will still be fine. Kahoot, so this is an online quiz. If you haven't already found it, it was in the email that went out to practices. It's supposed to be a bit of fun, but also a way to learn and to reinforce information. There are no prizes, sadly, and no one's looking at the leaderboard. But if that's your thing, then this is the link. And in case you need to, not sure about the answer, this one is false. This one, don't give it to 4-year-olds, please. So moving on to COVID-19 boosters. So as you know, it's either Pfizer or half-dose Moderna. The intervals now come down from 4 months to 3 months, and that includes people who are pregnant, and it also includes immunocompromised people who received a 3-dose primary course. So they're the only people really that should be getting a 4th dose, so having had their 3 doses and then they're getting their booster. It's causing a bit of confusion because we're now getting people who've had an early booster saying, can I get another booster? The answer to that is ATAGI have not yet said anything about that, so no, we're not doing that at the moment. Kerry Chant at the webinar, the RACGP webinar last week, was very much keen that people prioritise, particularly older people who received AstraZeneca vaccine, because they really need that booster to have some protection against Omicron. The item number is that 93666 number for the $10. So that's in addition to your usual second dose item number, and there's no additional bulk billing incentive for that because it's already an incentive number rather than an attendance number, I think is the answer for that. Novavax. Is there a hotter topic than Novavax? So just a few things about Novavax. Right, it's only for primary courses and not for boosters at the moment. As I'm sure you all know and has been widely publicised, it's a protein-based vaccine, more like a hepatitis B vaccine, and it's not a live vaccine. It's only for adults, but it has, ATAGI have said you can use it in pregnancy and breastfeeding, although they haven't got any safety data on that, obviously. Now it looks like it's 2 doses of 0.5 mils at least 3 weeks apart. I'm struggling slightly to find a proper local patient information or like proper information sheet. So I looked at the ones from Europe, and that's where I got my information from. That's about the 10-dose multi-dose vial and things. Presumably there'll be a mandatory training module soon. It wasn't live when I looked yesterday. Same for all the other immunocompromised people. They should receive a 3-dose primary course with a 2-month interval, so same as all the other vaccines. And the initial minimum order for practices participating in the first round, the first delivery is 200 doses, so expected from the 21st of February. Now, we think they're going to have a long shelf life and can hang out in your fridge for quite some time, but the full details not actually available at this time. So when I know, I'll let you know. Other bits and pieces about COVID-19 vaccines. So the AIR search function has now been updated. You can search by practice. Previously, it was just by provider. You can also put age limits on, so you could search for your 5 to 11s who have had no doses, for example. You can also search for people whose booster is due, but what you can't do at the moment is search for people who've only had 1 dose and need a 2nd dose. So that functionality is supposed to come in at some point. It's actually quite easy to run the searches, and they're quite quick to come back. So if you looking for an unpaid job to do, that's a good one. Timing about COVID-19 vaccines. Now, this one has been kicking around for a while about elective surgery, and the current guidance, certainly from Hunter New England, and I don't know about the Central Coast, but from Hunter New England LHD, is that we're sort of requested to avoid COVID-19 vaccination for 1 week before and 1 week after surgery, because the side effects of either might be confused, essentially, and you do run the risk of your patient having their elective surgery cancelled if they have had that injection in the week prior to surgery. So that's not an outcome any of us want. So it's just a heads up, really. Mammograms, I can't find any specific guidance, but of course, as we have all seen, lots of people are getting huge lymph nodes in their axilla, particularly after their 3rd booster, and more so with Moderna than with Pfizer. And so just best avoided if you know they're going for a mammogram, try and do it, the day after rather than the day before. Corticosteroid joint injection, no very clear Australian guidelines. The American guidelines say to avoid giving corticosteroid 2 weeks before and 1 week after the COVID-19 vaccination in case it has an impact on the immunogenicity of the vaccine and the vaccine doesn't work as well. But difficult to find really good, here we are, like we've been doing these vaccines for a year, but really, really difficult to find definitive guidance. And post-COVID-19, which is a hot topic at the moment, again, Kerry Chant suggested 4 to 6 weeks is fine to wait. Of course, you can give it immediately afterwards if they've fully recovered and they're safe to enter a high-risk setting. But it's not really medically indicated that early. And so waiting 4 to 6 weeks is fine. Obviously, leaving it 3 months if they've had monoclonal antibodies against COVID-19, because that will be ineffective. Temporary vaccine exemptions. Now, a couple of things have happened in this space just in the past week. So one of them is that one of the MDOs has come out with some really quite helpful guidance. And I think it is, if you've got questions about this, that's a really good place to look. And also ATAGI have updated their guidance. Whereas before they were saying you can have a temporary exemption for up to 6 months. Now they've reduced that time frame down to 4 months. And the language around this is really interesting. So what they're saying is that after you've had PCR confirmed COVID, not I had a rat test and it was positive, but you've had PCR confirmed COVID, then you can, not have to, not must, give an exemption for up to 4 months. So that helps. It's a bit more clear than it was before. It also says that you should not give the vaccine for 3 months after sotrovimab, which we know. And it's very clear that both ongoing symptoms from COVID and pregnancy are not reasons to not vaccinate. So those two things which have been, again, bandying around for a while, those are not a valid reason for exemption. And they're quite clear that there are very few situations where we actually need to fill in the forms, because there shouldn't be many times we have to give an exemption. The MDO advice is really sort of suggesting that if we're saying they should be vaccinated, which hopefully we are saying most of the time, then we don't need to fill in certificates saying that they can't be vaccinated. So that's where it says down there that if a patient's choice to defer vaccination is not a basis for certifying there's a medical contraindication to vaccination. So personally, I think there's not huge numbers of cases where you're going to need to do an exemption. I think a healthcare worker or aged care worker who's had sotrovimab or something, you know, and they've got mandatory vaccination requirements for work, and they need to have an exemption from the booster temporarily for 3 months. I think that's completely reasonable. But there probably aren't lots and lots of other cases. So how would you actually do it? So I went digging, and this is what I found. There is a New South Wales health form, but it's out of date now. It talks about 6 months. And I think this is a better way of doing it, really, to do it the official national way, which is with this exemption form IM011, which you can find online, and you can see you can tick a temporary vaccine exemption. This is a PDF. You can fill it in electronically and print it out, but you do have to sign it. So you're going to have to print it at some point. You'd be ticking acute major medical illness, and you'd have to tick all the vaccines and add Novavax, because it has to be an exemption from all vaccines for a temporary exemption. And then basically you print it out, scan it, sign it, scan it in, and then you have to go onto Proda. Of course, you all are in your mailboxes on Proda all the time. This is what it looks like, and there's a little button to upload forms, and that's how you do it. So it took me a while to work that out. Moving on to Medicare, so the phone item number for 20 minutes has been restored. It's 92746. It's not limited to MMM 6 and 7 like the other one is. The 12-month rule is not needed if the patient's got COVID, but if you're in isolation because you've got COVID or you've got a household contact as the doctor, then the 12-month rule still applies. The face-to-face item number has been updated to reflect that the COVID positive person might have diagnosed positive through a RAT test rather than a PCR, but you have to make sure they've uploaded the RAT to Service New South Wales or assist them to do so, and able to bill that extra $25 item number for seeing the COVID positive person face to face. That is never a telehealth item number. You can't use it for that. It does, but it doesn't have to be bulk billed. The 30-20 rule that we talked about before, probably a couple of webinars ago, has been deferred, so we don't have to worry about that too much at the moment. Pulse oximetry. Couldn't find very simple, straightforward guidance on who needs pulse oximetry. I think the caveat to all of this is always going to be if the doctor is worried about this patient and thinks that having pulse oximetry is going to be the thing that prevents them from having to have an emergency admission, then that's as good a reason as any. But this is a bit of a guide, so you can just probably read through that yourselves. But that pretty much matches to the people who've got risk factors for more severe disease. So some of these people, might actually be under COVID care in the community and have a pulse oximeter anyway, rather than being under GP care. But that just gives you a bit of an indication. Okay, I'm moving on now to reducing the risk of closure. Anyone who has seen me talk at any of these webinars will know some of these things already. I'm just going to run through them fairly quickly and just with a few examples. So I think the shift that needs to happen is that we need to understand that most of our risk of closure now comes from just not having enough people around to do the job, and that's because people are either sick with COVID or because they're in isolation because they've come into contact with COVID. And most of the risk is of us catching COVID or going into isolation from COVID comes from our contact with other staff members rather than with patients, as long as we are wearing good PPE to see patients face to face. So I think focusing on staff behaviours and the culture in the practice is really key. So the first thing is that you just do not come to work if you're not well. And I think that's still a really hard thing, because we've all been trained and brought up to just come into work when we were half dead. but not anymore. And encouraging everyone to get their booster, and then tea rooms, which I talked about a couple of weeks ago. And I'll talk a bit more in a minute. PPE, so everybody in a surgical mask. P2 for clinicians who are, particularly if they're seeing respiratory symptoms, and eye protection really for all clinicians at all times. Also, if you are going to be within 1.5 meters of each other frequently, then you should have eye protection on, bearing in mind that some of your risk comes from your co-workers who could easily have an asymptomatic infection, being a highly vaccinated population. And then the other stuff about telehealth and keeping people out of the waiting rooms, which we've talked about before. Surgical masks for patients, and just that tip that if someone comes in wearing a cloth mask, you can put a surgical mask over the top rather than risking the contamination of them removing their cloth mask and then moving on to a surgical mask. So, which is apparently fine. So this is the matrix. Hopefully you're all familiar with it. Now there is no public health response to us having COVID positive patients or staff members. It's down to us to work the matrix. So we're just going to look at it in a bit more detail just with some examples. So this is what the outcomes are from the matrix. We need to stay in the green. Being in the yellow or in the red is a pain, to say the least. Being in the red actually could close your practice. If you've got enough staff members who are on isolation for 7 days, it doesn't take much of that to close you down temporarily and mean that there's no service for patients. Even in the yellow, you know, there's this clause of having to wear a surgical or N95 mask all the time and not enter shared spaces, which is fairly difficult to police potentially, and also, you know, fairly difficult on staff, as well as, you know, repeated rats as well. So trying to stay in the green, and that's the way to go. So this is just an example, and sorry, this slide came out a bit busy, but so this is just an example. So COVID positive staff member, so they've been at lunch, they've had 35 minutes at lunch with other staff members, nobody's wearing a mask, there's no distancing, they're not 1.5 meters apart. All of the staff that were present have 7 days isolation. That's how dangerous tea rooms are. If you've got 5 of them, that will probably close a practice, and in some cases, just having 2 people away, it's going to close a practice. If you can minimize the time that you spend together, keep it less than 30 minutes in a closed space, and maintain distancing of 1.5, then the worst case scenario, if someone has been COVID positive in that, is that you're on moderate risk, so you continue to work with additional requirements in place, and that prevents you from closing. Of course, this is not, it doesn't mean that you can't catch COVID this way, but your risk is lower. So just thinking about how people move around the building, where people congregate, what you can do to make sure that you are minimizing your risk. Another example, COVID positive staff member might be a receptionist, where you have 2 receptionists working side by side for most of the day. Now, these are the different outcomes depending on how they behave, what your PPE guidance is, and how far away from each other they stay. So, you know, the outcome for the second receptionist who doesn't have COVID at this point depends on all of those procedures. So if one or both of them didn't have a surgical mask on and spent more than 15 minutes close to each other within 1.5 meters, that's it. That other second receptionist is off for 7 days, as well as your COVID positive receptionist. If they distance and they're both in surgical masks without eye protection, then you're good. The second receptionist can still come to work. If they are close together within 1.5 and they both have surgical masks but no eye protection, then you could be in yellow or red and lose your second receptionist. But if they are both in surgical masks and eye protection, even if they're close together, even if they are near each other all day, then your second receptionist can continue to work. That's as long as the first receptionist who has COVID wasn't coughing. Hopefully they didn't come to work coughing, because they obeyed the first rule of not coming to work sick. So it's just to work through an example of how these different policies can impact on your ability to keep your workforce at work. what happens when somebody is off with COVID. So these are actually difficult to find written down. So this is how I've written it down. So COVID case, minimum 7 days of isolation like everybody else. And assuming that they're asymptomatic, then they de-isolate automatically at 7 days. This is also assuming that they are immunocompetent and not immunocompromised. And the standard rules for everyone are then to avoid high-risk settings for a further 3 days, so no high-risk settings before day 11. And general practice has been confirmed to be a high-risk setting, although again, you will not find it in writing anywhere. So if it's essential that you need them to return to work before day 11, if they've got no symptoms or just minor, very minor, a lot of them can have a bit of a dry cough, let's face it, there's a lot of that going around after COVID. Then they have a RAT day 7. If that's negative, they can return to work day 8, but they have to have their mask on and avoid common areas until day 11. So that's so that because they still have a chance that they're going to be infectious up to day 10. Now P2N95 in that is really for clinicians. If your normal state of play is that you've got a surgical mask on, then because you're a receptionist, then apparently that's okay. If they're RAT positive, I think you're going to have to just make them do their further 3 days, no high risk settings, and return to work day 11 rather than doing repeated RATs all the time. I mean, it depends how desperate you are, I suppose. Otherwise, you could do a daily RAT and then when they're negative, bring them back, but you're not going to gain many days that way. Household contacts are more tricky. They are supposed to do 7 days isolation from the last contact with a COVID positive person. And then they do RATs as soon as they know that they're a close contact, and then day 6. And then if they develop symptoms, and if all of those are negative, then they leave isolation day 8, so after 7 days, and then avoid high-risk settings for 7 days. So if you've got a household contact and they're essential, you can bring them back if they've got a negative RAT. You can bring them back day 8 if they've got a negative RAT day 7, but they have to have a RAT every day, and they have to wear their PPE and avoid common areas until day 15. So these are 2 different scenarios. In the first scenario, COVID case, their infectivity is waning and you're trying to find the point at which they are no longer infectious. And in a household contact, 20 to 25% of them will become positive in the 2nd week. So you're trying to detect that as early as possible, bearing in mind that no test is perfect. So it is tricky, but that's my general advice. And yes, as we've talked about before, no routine testing or repeat isolation for 1 month post-COVID infection. And that's just another plug to submit your great questions. It looks like lots of people have asked lots of questions on here, which is wonderful. And all questions are great questions. So if you've got the question, probably someone else has also got it. And if we can answer it, then it will do everyone a favour. So happy to answer questions at the end. And I'm going to hand over to Mark Lowenthal, I think.
I think we're handing over to Joe. Right?
Oh, Joe, sorry. I will hand over to Dr. Joe Wood.
Team Mark.
Yep.
Thanks, Joe.
Thanks, Michelle. Sharing my screen. Okay, so hopefully everyone can see my screens there. I'm just going to do a very, very brief update because we've got to get to these questions. There's some great questions coming through. So really my capacity as a clinical editor for Health Pathways, and also as one of the GPs working with the COVID care and the community team with Hunter New England, and Mark as our director will be giving some contributions just a few slides in. So a quick review, there's been some changes around the maternity criteria that are coming into our service, where you can find those updates in the pathway. We just thought we'd touch base quickly again on assessing patients with COVID and some of the things to consider. And Mark's going to talk briefly around the couple of new antivirals that are provisionally approved by the TGA just recently. So Dr. Li Fong has been keeping us updated with new cases in our area, and that nice low line down the bottom is orange with our hospitalisations, and it looks like we're on a bit of a downward trend, but a bit early to say with return to school. This is a new flowchart from the ACI, or an updated one, I should say, really, trying to sort of map the patient journey, really, I guess, from a positive RAT or a PCR, and how they may sort of end up coming up to us without a referral from their GP. So they can complete a questionnaire. They're prompted to complete a questionnaire that will either immediately identify that they are low risk and okay for the self-management pathway, or that they may be increased risk and have a secondary questionnaire that they will be sent to fill in. And that one will hopefully identify nice and early if they may be eligible for disease modifying treatments and get a nice rapid referral into the local health district. And we have then sort of, as the local health district COVID care in the community team, have defined those extra criteria that we're using to try and capture the ones that we need to be monitoring, and the ones that we can try and get sotrovimab for, really. So those are the same as the last webinar we were at, and they're available on the health pathway. There's a clinical editor's note up the top of the pathways that you can have a quick look at. It's also embedded in the pathway in the management section as well. This is the new stuff about pregnancy. So previously we were saying all pregnant women should probably come through to the service, which was actually then being manned by the maternity team. They've now sort of gone back to more of a self-care model, just to draw an analogy with what's happened with our, the general sort of population, with their maternity teams being notified about their patients having COVID-19. And then a select few coming through to the COVID care in the community team for monitoring. The main group, of course, is trying to find any pregnant woman that may be eligible for sotrovimab and finding the ones that would actually like to proceed so that we can rapidly get that organised for them. And then looking at the cohort of pregnant women that are over 34 weeks that have comorbidities. So, that would be other women. This is getting confusing now, isn't it? So unvaccinated patients with significant comorbidities like diabetes or other chronic medical conditions that we could help monitor during their isolation period, but that would be in parallel with their maternity team. So all other pregnant patients, and this is, I think, where it's useful for GPs to know, is that if you have a pregnant patient that has COVID-19, they should register on the Service New South Wales app, and then that will hopefully feed back through to the local maternity team. So assessing and managing patients, I think that we're probably all getting very familiar with this now. Really, the key parts are, working out how sick they are right now, what are the red flags, working out if they need, they meet any of the criteria for sotrovimab, so any interventions. Really, with such high vaccination rates, it's the people that are still have some level of immunocompromise and most of our sotrovimab referrals now are coming from GP referrals, so people that are on immunosuppressants that their GPs have identified and sent the referral through for. Then really everyone else is on that sort of self-management protocol, which again, it's mostly about explaining the disease course and making sure the patient is familiar with the indications to seek review. What to do if they need to escalate their care. So that's either 000 if they're really crook. Is it a matter of just getting them to be able to rebook? And there's also, being aware of their local after hours access to care. And then there's 2 1-800 numbers that are listed in the pathway as well. There's a state one and a federal one. And we've actually been getting a few referrals as well from the My Emergency Doctor, which is the group that's been commissioned to do the 1-800 medical reviews. So they'll go through a filtering system and eventually get to a doctor if that's required. And they've been fairly high quality referrals, actually. It's been a useful tool for patients, I think. Then thinking about when you're talking to your patients, what their usual medications are. There really shouldn't be any reasons to change any of their usual medications. The only one exception may be oral hormone replacement therapy. Certainly with moderate to severe disease, that's ceased. And to be honest, really hasn't come up that many times. So I just thought it's worth reminding everyone to keep that one in front of mind. And then there's also the potential for budesonide for, again, quite a small cohort of people, and the criteria for that in the pathway. And then working out whether that patient is okay to continue self-managing after their consultation with you, or whether you want to have some level of follow-up with them. And Michelle's done a good job of identifying some criteria for those that may benefit from that oximetry, and it's great to see that we can get some access in primary care now as well. Most of the detail in the pathway is coming from various sources, but this is one of the key ones, which is the National COVID-19 Clinical Evidence Task Force. And you can have a bit of a Google of that, and it's got a nice little flow chart to have a look at too. So I'm going to hand over to Mark now, who's going to fill us in briefly about the 2 new antivirals. Thanks, Mark.
Thanks, Jo. And can I say it's been a pleasure working with you and with the other general practitioners in COVID care at home. I think that's been, for me, it's been a real positive that we've got sort of the hospital system and the GPs interacting, talking to each other, that I hope will last after the whole COVID story goes away. I'm going to talk very briefly about the 2 new antivirals that have just been licensed, or just been given provisional registration by the TGA last week. So clearly I've never prescribed them, I've never seen them, but I can tell you sort of what we know, and perhaps it is clear that they both work, and what we're going to have to find out more about or develop is really how well they're going to work, what they're going to prevent, who we should give them to, and how they, once we decide that, how we're going to get that to them. Unfortunately, I, of course, don't have the answers to all those questions tonight. All right, so there's 2 drugs, the molnupiravir, which is a nucleotide analog, sort of analogous to a lot of the nucleotide analogs that we use for HIV. And I've sort of put them, and the other one is a protease inhibitor. So in fact, it turns out that we use protease inhibitors against hepatitis C and hepatitis B and against HIV as well. And just by way of explanation, when the RNA or DNA code is read and translated into a protein, they're typically translated into long polyprotein strings that have to be cleaved into the individual proteins, and that's what the proteases do. So inhibiting those proteases prevents the viral proteins from being cut up and acting properly, either as structural parts of the virus or as enzymes. All right, so look, the first one, the Merck Sharp and Dohme drug, is going to be 4 capsules twice a day for 10 doses, so 40 capsules in all. And the protease inhibitor, which is in combination with ritonavir, is a little bit more complicated, and it's packaged it's packaged in such a way so that it should be clear, apparently, how to take it, but you have to take 2 of the Paxlovid, 2 of the Nemtrelvir tablets and 1 ritonavir tablet twice a day. The ritonavir, you may recognise that from an anti-HIV drug, though it hasn't been used as an anti-HIV drug for 20 years, but the reason it's there, and the reason it's still there in some of the HIV combinations, even though at 6 times that dose it is an HIV protease inhibitor, the thing that it does is inhibits P450 CYP3A, so one of the enzymes that metabolizes the active ingredient, and it allows that to be given. That's why it allows it to be given twice a day. So there are two licensing studies, and they both essentially have had the same, essentially the same enrolment. So adults, and in fact, non-pregnant, non-breastfeeding adults within 5 days of symptom onset, who have a risk factor which makes them at risk of progression to severe COVID. So 100% of them have been unvaccinated, and they weren't allowed to have any antibody therapy. And when you look at the breakdown of the MSD drug, just over half of them had Delta, and none of them had Omicron. And given that the Paxlovid, the Pfizer drug, was essentially studied in the same setting, I think we'd find the same result. So unvaccinated people with risk factors who are not allowed to have sotrovimab or antibody, mostly with Delta, that group is the group that is most likely to progress to hospital or death, which was a final endpoint. So I guess you'd have to say, when you look at the results, that's the group that's going to have the biggest risk, and if the drugs work, it'll have the biggest effect. Can we have the next slide, please, Joe? Or am I controlling the screen? No. Great. So look, and I would have to say that the result for the MSD drug was from a paper in the New England Journal of Medicine, whereas the results for the Pfizer drug were from a Pfizer press release. So I think you need to keep that in mind, that it really hasn't been subject to much peer review. And the second unfortunate thing is that, and that we know because it's been published, is that the molnupiravir study had an interim analysis when they'd enrolled half the patients, and that showed virtually identical results to the Pfizer study. But by the time that they'd made the decision to stop the study early, they'd already enrolled a sort of equal number of patients. And so when the final study came out, it included the full number, and by then the effect had dropped in half. So the results were that I mean, lots of results. The bottom line, the primary endpoint was a composite of death or hospital admission, and the MSD drug, the molnupiravir, had an absolute reduction of 3%. That's from 9.7 to 6.8. And before anyone points out that subtracting the two doesn't give 3, that's because of some sort of rounding error. The difference was 3%. Oops. And actually, I've written the wrong thing in there. But and the difference in that composite endpoint was 5.8% in the Paxlovid group. The original difference was actually 6.8% in the molnupiravir. And that's actually a mistake. That should read 1.3%, not 3% in death alone. So the absolute reduction in death of 1.3 or 1.4%, which happened in both studies, is actually quite a lot of deaths, considering the number of people with COVID, but it's in unvaccinated people with risk factors who had Delta. So it's going to be sort of an order of magnitude at least greater than with Omicron, unless we choose really high risk patients. So that's all I'll say for the, I haven't actually put a thing on side effects, but actually the side effects, placebo compared to active drug, there's very little difference. Slightly more nausea, about 0.7% more nausea in the molnupiravir, and similarly with diarrhea in the Pfizer drug, a tiny bit more diarrhea, but less than 1% difference. So in terms of tolerability, they're quite well tolerated. Okay, and I'll leave any other questions that you want to ask. If I can answer them, we'll talk about them in the discussion. Thanks.
Thanks, Mark. So that's us really. We're expecting a new phone number for COVID care in the community, but we'll update that as soon as we get that available. So I think we're over to questions. Michelle, Kimberly.
And we'd just like to welcome Dr. Karen Douglas for the panel discussion as well, joining us from the Central Coast. That's great. So I don't know if Kimberly's still there.
I am online. Can you hear me? I'm just going to find my camera, and I am back on.
Perfect. So we've got a few questions. A few of them have been answered. It might be worth going through some of the ones that have already been answered. I saw a question there about stopping oral contraceptives. Do you want to comment on that, Joanne?
Oh, yes, I should have been clear. My apologies. I should have really clarified. Please keep on oral contraceptives. It's just for oral hormone replacement therapy. And I think the particular target is the moderate to severe severity illness. You should consider it in the mild illness as well.
Wonderful. Okay. Let's have a look through.
Now I've got some questions for Mark that I've prepped him on. So I might give this one to you straight away if that's all right, Mark. Is that all right, Michelle? Is sotrovimab now indicated for high-risk COVID positive people that have not yet had a third dose? So that's come out in the most recent ACI document that we might consider that group. And we haven't really altered our practice yet with COVID care in the community. Did you want to have a quick chat about that, Mark?
Look, I think the first thing I did when I saw that was to look at the numbers. And it works, reading off some of the graphs, it works out at the moment, that's about 42% of the eligible population who and of course that's because because of the times it's gone from 6 months down to 3 months in less than 3 months. So that's an awful lot of people who you'd be offering sotrovimab to. So when I look at that, I sort of cringe. And I guess remembering that the actual sotrovimab licensing study was in completely unvaccinated people. And we know also, and I think it's an important message, that the AstraZeneca vaccine, that sometimes several months after having 2 doses, you're not protected from infection with Omicron. But that doesn't mean that you don't get protection from it. That you still get protection against hospital admission and death. And there's still T-cell immunity, and it's still boostable. And the fact that the single dose of Pfizer or Moderna gives such good boosting for AstraZeneca, sort of shows there is still immunity there. So in some ways, that's sort of giving the wrong message. At any rate, my feeling is, okay, we can look at that, and especially down the track when that's not an overwhelming number of people. But I think people, you still, the most important message is vaccination is good, and you still have some protection from vaccination. So we'll see what happens. But it's truly an evidence-free zone because the study was on unvaccinated people, and definitely helps. Yeah.
Yeah, thanks, Mark. Michelle, can I check another one at Mark, just because there's a little cluster of people asking about retesting when symptomatic. So they've got COVID and they've retested. Don't retest. It's probably a message. And what to do with a positive at day 7 or a positive at day 12, for example, that's still symptomatic. So we've had lots of experience with this, with COVID, the COVID care in the community team and relied very heavily on that ACI document that looked at people's infectivity right at the end of their isolation period, and essentially no one's infectious after day 10 really. Do you think that's, do you want to comment on that one, Mark?
So, as I'm sure you've heard me say, so I must, firstly, I will say that for many, many months after the first COVID wave, I don't know if you know Eliza Milliken, one of our advanced trainees, and myself, spent a lot of time and had a lot of heartache over people who tested persistently PCR positive, and there were people in the healthcare system who are perfectly healthy, and one in particular who we actually wrote up was positive for 5 months. So that was 5 months off work for that person. So I do come from a point of view where I've already been burnt by the whole thing. But I would say, but I'd also say, of the 350 million people in the world who've been diagnosed with COVID, none of them, not one of them has been shown to have acquired that from a person more than 6 days after their symptoms started. So that's something to bear in mind. If you think about it too hard, you'll realise that's actually quite a hard thing to prove. But and you've probably seen the case reports of the occasional people with some very severe form of defect in immunity who still have cultivatable virus more than a year after the disease. But having said that, we can find other viruses, JC virus, all herpes viruses, polio, vaccine polio, in some people years afterwards, and we don't lock them all up for the rest of their life. So we feel very strongly if somebody's recovered, they can go, and especially now that there are, you know, so many people in the community with COVID that we know about and we don't know about, it seems sort of awfully unfair to let somebody, to sort of lock somebody up when actually their contagiousness is absolutely tiny or zero. So we discourage people from retesting. There are other things I've done which we have done which probably aren't applicable now that there are certain people with COVID. We have tested their anti-spike antibodies and shown that they have developed antibodies. So we've done that in a person with a T cell, so with a B cell lymphoma who had their B cells seemingly ablated, and they made their own antibody. So we use that as an excuse for not testing, but the pathology people will kill me if you send too many of those in because it's a complicated test. Yep. So if they're better and they're more than 10 days or more than 14 days, I just let them out. And in fact, now that everyone's actually receiving a text that gives them a date, and sure, there's a lot of stuff on that no one ever reads that sort of gives them an out, but basically they have a piece of they have a screen or a piece of paper that says you're out on this day. That's actually very convenient.
That's right. It's almost something that we don't have to police as much anymore. But really, if you get to day 14, you're going to have been substantially improved from where you were at the beginning, and you can even meet the SONG criteria, because that's really where that comes from as well. So yeah. So
it's and infection's never been described from those people, and so if you do describe one, you can be famous. You can write it up as the first case ever of something in 14 days. Yeah.
Yeah, I think a lot of the confusion comes from the differences with the federal guidelines and then state-based ones, where state-based ones you don't need to retest again. But then if you had a look at the federal ones, they do mention retesting at day 7. But certainly the New South Wales guidance is don't bother retesting, because you get yourself into these little spirals. Have you got a question there, Michelle?
I was just going to ask Karen maybe to answer the question about can we use AstraZeneca as a booster? I did see it there. I'm just trying to find it again. So,
well, I guess on if you would only use AstraZeneca really if somebody has had a severe adverse reaction and is unable to receive at this stage an mRNA vaccination. We're recommending that you don't give a third AstraZeneca because their immunity is probably less likely to be as effective from the AstraZeneca. There are certainly people who are asking for it, and I think they have possibly, concerns about the mRNA, which you can often talk them down for. But usually we don't recommend AstraZeneca unless somebody is truly allergic to or had a hospitalisation and a recommendation from one of the specialists to not have mRNA vaccine. I guess when Novavax comes in and we can use it as a booster, it will assist those who are a bit anti-mRNA for some reason, whatever it is.
Now, I'm just aware we're very tight on time. I don't know if we've got any more time, Kimberly, to answer any questions, or whether we should take those remaining questions on notice and wrap up.
I think, well, there's one more question that I thought, and it may come to yourself, Michelle, and it's a good question. So I just thought if we can do one more, perhaps that's come through the chat, then we could take the rest and follow up with a one-page response after the webinar. I just noticed that there was a question up there about just touching on the exemptions. And the question is, so what if someone got an exemption last week for the 6 months post-COVID? Obviously before the 4-month change, is that still valid?
Yeah, I don't think there's anything you can do about paperwork that's already gone out. I think I don't think you can recall it. So I guess if you've already given the exemption, you're given the exemption, just like if you've previously given a medical certificate, it's done. So I don't think it's retrospective. There's nothing in the guidance saying we had to go through any exemption we've done before or anything. But good
Beautiful,
question.
thank you. Over to you, Jenny. I think we will pop the rest that have come through that haven't been answered. There's a couple more probably for Mark too, just to give you the heads up, Mark, there's a few more coming your way, and we'll send that out or add it to the website when the webinar recording goes up.
Thank you so much, everyone, for giving your time tonight. Yes, and as Kimberly said, we will have a recording of the webinar, a copy of the slides, and the Q&A sheet will go up in the library on the PHN website. Thanks, everyone, for joining us, and we should be back in another fortnight with another COVID update. Thanks, everyone. Good night.
Thank you.